A continuación voy a hacer la presentación de la doctora Andreea Seritan. Ella nos va a estar acompañando vía Zoom. Como tal, la doctora es psiquiatra geriátrica, profesora de psiquiatría clínica en la Universidad de California en San Francisco, realizó su residencia en el Baylor College of Medicine en Houston y completó la subespecialidad en geriatría en la Universidad de California de Los Ángeles. Sus áreas de interés incluyen las manifestaciones psiquiátricas de las enfermedades neurodegenerativas, la educación médica basada en competencias y el impacto del cambio climático en la salud mental. Ella es miembro de la Academia Hail T. Divas de Educadores Médicos, autora de más de 100 publicaciones y fundadora del área de distinción en neurociencias clínicas de la Residencia de Psiquiatría de la Universidad de California en San Francisco. Ok. Vamos a hacer el enlace, por favor, con la doctora Seritan.
Hello, hi, can you see me and hear me? Thank you so much for inviting me. Thank you so much, Dr. Duran, and I could hear your introduction. I cannot speak Spanish, but I could hear a little bit. Thank you so much. I am honored to be here, and I would like to share with you one example of implementation of entrustable professional activities. This is just one example from our institution, and I do not speak for the entire United States or even for the entire geriatric subspecialty. As Dr. Duran mentioned, I am a geriatric psychiatrist, meaning I am a psychiatrist for older adults. And I work at the University of California, San Francisco, where I am also a member of the new UCSF Center for Expertise in Entrustable Professional Activities. I have a lot of people to thank, starting with Dr. Ole Tenkate, Dr. Bruce Miller at the University of California, San Francisco, and these are all my colleagues, as well as the Graduate Medical Education Office at UCSF that helped us build the workplace-based assessment form I will share with you in a few minutes. I have no conflicts of interest, and I am presenting my personal opinions, my personal views. My opinions do not represent the views of the university. As you know, competency-based medical education is a movement in medical education and expanding actually into health professions education. So we can call this competency-based education. And it has taken the world by storm over the last 2 to 3 decades. Which means that we are mainly focused on outcomes. What do we want our learners to be able to accomplish, and how do we want them to behave in the professional realm once they have graduated from our programs? And this is not as much based on time, the time that the learners spend in training. So it is outcomes based, of course, the ultimate outcome being patient care, excellent patient care. And as you probably know, this has been implemented in the Netherlands, in the United States through our Accreditation Council for Graduate Medical Education, ACGME, as well as in Canada. And my colleague, Dr. Cindy Grief, I know she sent a recording, and she will explain a lot about the CanMed's competencies. But in the United States, we have these 6 core competencies for the graduate medical education, meaning people who have already completed medical school, graduated medical schools. And these 6 core competencies include medical knowledge, practice-based learning and improvement, interpersonal communication skills, systems-based practice, professionalism, and patient care and procedural skills. So those are the 6 main competency domains in the United States. And as I mentioned, the CanMed's framework will be discussed in a lot of detail by my colleague, Dr. Cindy Grief. So when learners move through the training programs, we can also observe and quantify some milestones. And the milestones are observable markers, so things you can actually observe and say, I think they're able to do this, or they're not yet able to do this, meeting those criteria. And those are the milestones. I have an example here. For example, for the psychiatric evaluation, you can see the levels 1 through 5, and these are markers of the trainee's ability to progress along a developmental continuum. However, the milestones and the competencies are difficult to operationalize, and as much as people have been trying, we have a system where residency programs, graduate medical education programs, residencies and fellowships have to communicate these milestones and competencies. And I actually just completed the evaluations for my residents and fellows last night and this morning, and you have to be able to state where they fit along this developmental continuum. So along came Dr. Ole Tenkate and his group and the entrustable professional activities. So knowing that the competencies and milestones are difficult to quantify, Dr. Tenkate and his colleagues, and I know Dr. Duran knows a lot about this because she is one of the graduates of the course led by Dr. Tenkate and his colleagues. They came up with this notion of entrustable professional activities, meaning essential units of professional practice that are defined as particular activities or responsibilities that the trainee can be entrusted to perform. So entrusted is the word here, to perform unsupervised once they have attained sufficient competence. So meaning you as the supervisor in a clinical environment can check the box and say, I entrust the resident or the fellow to perform this particular task or activity tomorrow. So this is, as opposed to observing things in the past, this is what you anticipate that they will be able to do in the future. And of course, there are many EPAs for many specialties. I just want to give you some examples in psychiatry. For us, managing a psychiatric patient longitudinally, managing a psychiatric emergency, assessing, for example, decision-making capacity, and there are many others. Actually, in psychiatry, we have about 10, but I only gave you 3 examples here, but they are not utilized by all graduate medical education programs across the country, as opposed to Canada, where again you will hear from Dr. Grief very soon, where they have been established and co-developed, and all graduate medical education programs are using them. Now, EPAs, so entrustable professional activities, they map to multiple competencies and milestones. For example, if we take here performing an appendectomy, as you can see here, in order to be able to complete this activity, this task, a resident or a trainee needs to know, to have knowledge of medical knowledge, patient care. I would say also the communication skills are very important here. So the EPAs actually compound more milestones and competencies and putting them all together. Another way of looking at this, I really like this from a recent paper from Montgomery et al. This was from surgery. What they explain here are that the milestones are, in a way, the building blocks. So the resident has knowledge of the varying patterns of disease presentations, for example. Then you take these building blocks and put them together in the competency domains, the 6 competency domains that I showed you. And maybe not all of them are relevant to a particular EPA, but many are. So this is like you're building the wall, you're putting the bricks together. And then the EPA is making the house, building the house, and putting the roof on top, putting it all together. In this way, we would say, I would trust this resident to treat a patient with gallbladder disease, for example, with, let's say, indirect supervision. So that's level 3. Another way of looking at it is, without belaboring the point, competencies describe people, describe the person. They're more granular. So they describe the knowledge, skills, and attitudes and abilities that a resident or fellow must have in those domains, whereas the EPAs describe work. They do not describe the people. You won't say that the person is competent. You say that they achieved, you observed them complete this task, this entrustable professional activity. They're more holistic, as I showed you, like the house with the roof. And there are some examples here from my colleague, John Young. Now, we use different scales. This is the scale that is used most commonly, at least we use this in our residency program at UCSF, the entrustment scale of level 1 through 5. From 1 level, co-treat, an attending is there with you, so the faculty, meaning the supervisor, maybe demonstrates or co-treats along with you. Now, level 2, we observe and provide proactive supervision. We are there in the room for the entire procedure, for example. Level 3, direct partial. We're only in the room for a portion of the visit and verify key findings, which is what I usually do with my third-year level residents. Level 4, they're already more advanced. They may be a fourth-year graduate medical education or a fellow indirect with attending nearby, and they can be called and available as needed or if needed. And then level 5, they're independent, ready for unsupervised practice, so ready for graduation, and they actually often are able to teach others as well. So level 1 to 5, this is the scale we're using at UCSF. Now, moving on to geriatrics EBAs. In the United States, the Association for Geriatric, the American Geriatric Society, AGS, put their heads together longer than a decade ago. So as you can see, this paper was published in 2014, and they came up with 12 EPAs and we call them end of training. So what should they be able to do by the end of their training? And we call this end of training geriatric EPAs. I gave you some examples here. And then you have all of them here, and I'm happy to share with you any of the papers or the references that I have cited. But basically, this is what they think a geriatrician should be able to do independently in practice in any of these settings, inpatient, outpatient, palliative, or any other levels of care. So now I'm going to share with you the implementation example I mentioned. At UCSF, we have this clinical neurosciences area of distinction, which I very proudly launched together with my colleague, Dr. Bruce Miller, who is a behavioral neurologist. And this is a training track, a specialized training track for psychiatry residents interested in working at the interface of neurology and psychiatry. It is focused on geriatric psychiatry. As you will see, a lot of the patients have, they're more older adults and have many of the conditions that we see in older adults. We use competency-based education elements. So in order to make this feasible, so it would fit with people's interests and career paths, we are using CBE elements, namely patient logs, and direct observation learner assessment, an original form that we created particularly for the purposes of this AOD. I do want to emphasize that this is not fully a CBE model. This is a hybrid model. We have time variable training embedded into a fixed 4-year duration psychiatry residency. So time variable training, but they still have to complete all 4 years. At the end, they get a diploma and they get a certificate of completion of the area of distinction from me. The residents can join or withdraw from the AOD at any time. Most join in our 3rd year, but I have someone who just started as an intern, so very early on in their 1st year, and then some people join in their 4th year, rarely. We created 10 dedicated elective rotations and the neuropsychiatry lecture series, add rotations every year based on interest and faculty availability, and the faculty are selected for their interest and expertise. Here I'm showing you the basic elements of the core rotations. It is very important to teach genetics, talk about neural circuits, obviously clinical presentation, psychopharmacology, and neuroimaging. And this is a pet example, just as an example. And here I'm showing you the team I am very fortunate to work with at the Movement Disorders and Neuromodulation Center. I will actually see them very soon at our Congress for Movement Disorders very soon. Which is the reason why I couldn't be there in person, because I'm traveling to this other conference. The rotations we put together, you see them here. I mentioned Memory and Aging Center, so that is for people with Alzheimer's disease and frontotemporal dementias, the movement disorders where I work. A geriatric psychiatric clinic is crucial because many of the residents use their experiences there. We have psycho-oncology, patients with cancer, HIV, sleep disorders, epilepsy, all kinds of rotations, again, that we put together. And it's like a menu of rotations that the residents can choose from. They don't do all of them. They choose one or two, depending on the elective time and their interest. Now, in order to meet the CVE criteria that I told you about, they have to fill out a patient log. They have to have at least 50 patients, and one patient may count for more categories, more than one. For example, you could have someone with Parkinson's disease and dementia. They count twice, in a major neurocognitive disorder and in a movement disorders category. You can see here the categories, and as you can see, a lot of these conditions are conditions that you see in older adults. Although they could also be younger people with ADHD, tic disorders, or Tourette's, but mostly, as you can see, adults, midlife or older adults. With Dr. Tenkate's support, we sat down and we created an EPA for this. I specifically asked, how can we put this together, operationalize this, so we can take this and give it to the faculty in order to be able to assess residents' progression and entrust the residents. And you can see here just an example, just the top of the form. And then we took the CPA and transformed it into a workplace-based assessment, which is available in our platform. I'm not sure if you use this platform. It's called MedHub in the United States. And that is our evaluation platform where the faculty go in and submit evaluations for the residents. They can select from the following activities that they directly observe the resident. They can select more than one. Usually they do. And then all these activities have to meet entrustment level criteria that I showed you and have to apply to the patients in the diagnostic categories listed previously. So for example, if you are in the geriatric psychiatric clinic and you see a patient with Alzheimer's disease together with your resident or fellow, and then you can say, okay, I watched them, I observed them perform a diagnostic evaluation. I observed them interpret relevant laboratory studies. I observed them provide pharmacological treatment. I didn't watch them do supportive psychotherapy, for example, but you can check all of those. It takes 1 minute. You can do it in real time. This form is available on the mobile devices as well as on the computers. The form looks like this. Actually, we just revised it a little bit in January 2025 based on the experts, Ole Tenkate and the EPA experts' advice. And the residents or fellows need to meet at least 5 assessments, so at least 5 times to be observed for each one of the activities that you see listed here, the 7 activities. I'm sorry, the form is tiny, but I just want to show you what it looks like. It only takes 2 minutes or 1 minute. And then they have to reach at least one level 5 rating for each one of the activities to get the graduation certificate from us, except for number 2 and number 4, imaging studies and neuropsychological results, testing results. Those are outside of their scope of practice. A level 4 is sufficient. We created a faculty MedHub guide so people don't get confused about what they're supposed to do. And then here I want to show you, just as an example, how we use this form in its previous iteration between July 2019 and October 2024. I had 13 residents with 422 activities on 85 forms completed by 6 different faculty members. And this is one resident, and I just want to show you, it looks like this. So you can see time 1, time 2, and different attendings, A1, A2. But basically, as you can see, they are observed in a multitude of activities, and it only takes 1 minute. Again, you can do it while you are observing the resident on your phone. For the outcomes, and this is my last slide, I'm going to stop now very soon. 11 residents have completed the AOD, 1 has withdrawn, and 3 are currently enrolled. Most residents complete the requirements in 12 months, so it doesn't take very long. But again, this is not time-based. This is a time variable format. The residents like it. They actually think that the CBME approach is a strength because they get frequent formative feedback, a lot more than they do in their actual residency training overall. They appreciated the general supervision time because we have more time built in. They wanted more training on neuroimaging, and they wanted us to record lectures. This is, as I mentioned, an interprofessional learning environment, so it's great for our psychiatry residents, for the movement disorders fellows that work with us, for the behavioral neurology fellows, and then also 4 graduates of this area of distinction have actually joined the faculty and are now my colleagues. One thing we haven't done yet, we have not collected faculty feedback, and that's coming. These are my references, and again, I'm happy to share any of this with you. And then this is my email address, and I believe we will have Q&A later after we listen to Dr. Grief's presentation.